So thank you very much for the invitation, the kind invitation, and after the presentation of this morning and actually also the conclusions from Dr. Kolesnienko, I really liked how he concluded, and I think that if I had to think now, I would change the title of my presentation, because I think he said at the end, and I thank you also very much for the translators that helped me. After 50 years of ARDS, we learned that mechanical ventilation is an art. At the bedside, there are many guidelines and methods to titrate PEEP and recruit the lungs, but we need to understand the underneath problems. And I really very much embrace this suggestion that was given at the end of the morning presentation, because mine is going to be really a applied physiology to a problem of patients with acute respiratory failure. So, I'm actually originally from Italy, and I moved to the United States like it was year 2000 when I finished my medical degree. And when I went to the US, the problem of, we heard this morning, the problem of baby lung, as we call it, is different, because the size of our patients many times exceeds what we really think. So the baby lungs are because there is a large mass of a patient many times. And what I had to deal with, for example, in this patient, is that how would you define this patient? This patient was one of my patients when I was a resident, and this was a lady of about 320 kilos and the BMI around 80s. So the level of, as you can see, I mean, I would not define ARDS because there are only atelectasis at the base of the lungs. The problem is here, it's a recruitment of the lungs and the homogenization of the lungs. And in fact, going over the data from my hospital, what I discovered was that most of our patients, the majority of the patients with hypoxic respiratory failure are obese. And I think there is a slightly difference. We are not talking about ARDS, but we define them incorrectly, I think, many times as ARDS, while instead these patients mostly have atelectasis. So, and here it's a problem that I think it's underestimated. This is what happens in the United States over the past decades. As you can see, the obesity epidemiology is not really high. There are only few states that have the incidence of obesity is about 10%. But then 10 years later, in 1995, obesity becomes like about 10–15%. In the year later, again in 2005, it's again getting a larger population until 2014. This is the latest report. More than 30% of Americans are obese. That means a BMI more than 30, which means that more than 100 million in the United States are obese. Basically, 1 out of 3 patients in the ICU are obese. So it becomes and I think it really becomes a problem of understanding more about how to treat and apply physiology to these patients. This is from the WHO, the obesity around the world. As you can see, there is multiple countries, especially in the Americas, but also Middle East, Europe, and Russia is about 10–20% of obesity, but it's also increasing also here. So what do we know? We know from the ARDS-NET trial, the group that are studying ARDS in the States, that patients are at increased risk of hypoxia by weight. So going from underweight to severe obese, hypoxia increases. They say ARDS increases. I have some doubts, and then I can show you some data. I think I would not define as ARDS, but instead hypoxic respiratory failure. If patients are obese, they are more at risk of tracheostomies, they are more risk of staying intubated for a long period of time, and also they are, as you can see, they have increased ventilator dependency, as I said. The first study, now going to physiology, that really, I think really helped to understand better approach of ventilation to this patient population comes from the Edestierna group. They had 30 obese patients, they divided in group of 10. The first group of patients was induced under anesthesia and then ventilated without any PEEP, so at zero end expiratory pressure. The second group was instead induced, intubated, and then applied a recruitment maneuver that was defined as a 55 centimeters of water for 10 seconds. And then the last group instead was induced and then recruited with 55 centimeters of pressure and then PEEP at 10. I remind you, these are normal lungs, normal patients with normal lungs, just obese. And here is what they found on the CT scans, that after induction, when patients were awake, they were the normal in the first quadrant on the upper left, normal lungs. In the second, after induction, there are atelectasis forming in the basis of the lungs, and then in the non-dependent region remain atelectasis up to 20 minutes later. When a recruitment maneuver was applied, there was a minimal benefits, but only when a recruitment maneuver and PEEP were applied, lungs remained open and ventilation was, and the patients were not hypoxic. So, with this in mind, the question is how much PEEP is enough for this patient and how should we titrate and what methods should we use to titrate ventilation in these patients. We know that PEEP recruitment maneuver in these patients improves a reverse atelectasis, reverse also expiratory flow limitations and improves also oxygenation. But reality is the question is how and how should we apply pressure? So the first study that I presented is a study that we performed at MGH. Our questions were really, can we reverse atelectasis and improve oxygenation in patients with, when they came to the hospital, had normal lungs, but they became hypoxic after intubations in the ICU? And what PEEP titration should we use it? We report this in critical care. So we investigate two methods. One was a transpulmonary pressure methods and the other decremental PEEP trial at the bedside. So what is the best method? Just in short, transpulmonary pressure is the pressure that is across the alveoli. So it is really the alveolar pressure minus the pleural pressure. And the pleural pressure, we use an esophageal balloon in the esophagus just to measure, just as an approximation, a surrogate for pleural pressure. And as you can see now in this, so how do we do? Oops. It's okay. There was a slide. So how do we measure adequacy of a PEEP titration? As you can see in the upper quadrant on the right, there is a blue line, which is the ventilator, the airways pressure, and then there is a esophageal pressure, which is the black line. And what it shows is that at the end of exhalation, the pleural pressure is higher than the airways pressure, and instead at the end of inspiration the airways pressure is just above the pleural pressure, suggesting that the transpulmonary pressure is negative at the end of exhalation. Thus, in order to have adequate ventilation, you should increase positive and expiratory pressure above the pleural pressure or esophageal pressure. The second method that we used was to titrate by, there were here some, there isn't anymore, it's okay. Here, the second method we used was instead to use a decremental PEEP trial. And what you shows here is that we went from 25 of PEEP to 5 of PEEP, and we decided that the best PEEP was where the compliance is improved. That means elastance, which is the reverse of compliance, is lower. So at PEEP of 15, you have the lower level of compliance, of higher level of compliance, lower level of elastance. So the best system, the respiratory system. And the second is, as you notice in here, in dark bars, I also shows the chest wall compliance, which is unchanged. And that was against our hypothesis. We hypothesized that in these obese patients, the chest compliance was increased. Reality is that in this patient, for example, chest compliance doesn't increase or decreases with changes in PEEP. What it changes instead is only lung compliance. That is due to the formation of atelectasis. How did we perform recruitment? Here everybody has its own recipe, but for ICU patients that many times are on pressors and we want to be very gentle, what we use is a pressure control ventilation, and we give like 10 breaths per minute, 3 seconds of inspiratory time and 3 seconds expiratory time, and we increase PEEP from 15, we arrive to 35, which means plateau pressures about 50 or 55 maximum. And then we maintain that for a minute, and so we give like just the time to distend all the parts of the lungs, and then we perform a decremental PEEP trial. So this is our patient. We did this study in 14 patients. This is the BMI 50 on average, and what we found, and what we did was really 3 phases. We did, when the patients came in, we did a baseline settings of measurements at the level of PEEP that was titrated by the ICU team, and then we did 0 of PEEP. We did another measurements. We increased PEEP to transpulmonary pressure equal to 0, and then we did the last part of the study was recruiting the lungs, decremental PEEP titration, to validate which method was best to use in these patients. What we found was that the end expiratory lung volume by wash-in, wash-out of oxygen was equal really in the transpulmonary pressure with or without a recruitment maneuver. So the volumes just improved after recruiting the lungs, or not, but just increasing the PEEP. And the transpulmonary pressure were extremely negative both in inspiration and during exhalation, during baseline and ZIP. But when PEEP was raised, at positive transpulmonary pressures, as you can see, was both by decremental PEEP trial and by transpulmonary pressures, we had positive pressures. And what is interesting in this graph is that compliance increased only after recruitment of the lungs. Despite and expiratory lung volumes were increased in both methods, with or without recruitment maneuver, the positive transpulmonary pressure with recruitment maneuver decreased the compliance. suggesting really recruitment of the lungs. PF ratio improved only after transpulmonary pressure, positive after recruitment. So, and here I think is the interpretation of our data. If we go back to the PV curve of the lungs, in the obese patients, what I really propose is that there is a shift of the PV curve down to the right. So if you think about at normal FRC, so it's at zero of so atmospheric pressure, what happens is that due to an increase in pleural pressure, in red, it's, as you can see, at the normal FRC that you have like about 2 liters, now because of the shift to the right, your FRC is down to 500. That is what is commonly seen in this patient as zero PEEP. But however, which is like suggesting extreme severe ARDS. But that's not true, because the compliance and the curve of a PV curve of the lungs is exactly like normal if you move the curve to the right, so by increasing PEEP. And then here for hemodynamics, patients were stable only during the recruitment maneuver, as reported by many. There was just a slight decrease in pressure, but overall hemodynamics remained stable. As a conclusion for the first study, we showed that basically against our hypothesis, chest compliance of these patients is absolutely normal. What is changed in this patient is really the lung compliance, because it's due to atelectasis. And whether you use a transpulmonary pressure or decremental PEEP trial, we found the same level of PEEP, which was about 20, best PEEP in these patients. But the important thing, I think, as was said this morning, is really stick to the method you are able, that you know and you are practicing. But we found the same level of PEEP as long as there was a recruitment maneuver associated to that. But one would say, okay, now, however, we don't have always a normal lungs. We usually have also patients like that comes to the ICU like this. This was a patient that 40 years old with diagnosis of lower leg necrotizing fasciitis. As you can see, the folds of obesity is pretty large. She was a patient, or about, also this patient was a BMI around 80, and with maximized with pressure, with norepinephrine, vasopressin, and methylene blue. So, and this was like the CT scan, and that I think that nobody would, after a long, we were able to bring it to the CT scan against the radiologist. We were able to fit her through the CT scan. Many times patients like this are impossible to bring it to the CT scan, and many cannot even enter in the CT scanner. So as you can see, there is the consolidations, and there are also a pattern that really look like for ARDS patients. So the second study that we had done and we presented to the American Thoracic Society this year was are we able to translate the data that we found before in healthy obese patients, in patients with more severe respiratory failure or septic shock like this patient. And second, can we monitor at the bedside ventilation and recruitment of the lungs? The reason is that many times these patients are very difficult to travel with because of the size of these patients. So to have monitors at the bedside would allow us to clearly is an advantage. So what we did was first we started to a level of PEEP that was considered in the ICU. These were average PEEP. It was between 10 and 14. Patients that were given a recruitment maneuver by pressure control ventilation, and then the decremental PEEP trial, and then again we re-recruit the lungs and left at the titrated PEEP. So this was before the study of our patients within the 24 hours from entering the studies. These were the CT scan as we saw. And what we did, we applied electric impedance tomography, which is basically an impedance, it's a belt that goes around the chest. And by impedance, you can monitor ventilation. And it's an electrical current that goes throughout the chest. And so you can actually see lung ventilation in the lungs, in the different region of the lungs. And we performed a decremental PEEP trial, and what it shows here is that in red you see basically going from 34 of PEEP down to the 15 of PEEP, there is an increase in collapse. That in red is a collapse of the lungs by impedance. For example, as you can see, at 25 of PEEP, these patients start to collapse in red because it's going increasing. And in blue, instead, is a hyperdistension. Again, by electric impedance, you can measure if the alveolar space is hyperinflated or deflated. And the best compliance appears to be at 25 of PEEP in this patient. Compliance also is number of compliance is also reported in the second column. As you can see in the lower graph, there is going from right to left, there is a very high driving pressure, which is from the blue line to the red line, and it decreases in driving pressures and then again increasing at higher PEEPs. And this is what you can see from before. This is the monitoring basically because of the impossibility to bring this patient to the CT, and also we are able to see where ventilation goes in these patients. So from the mostly anterior part of the lungs, after recruitment in the posterior part of the lungs. So this was our patient after 6 hours, the chest X-ray and the PF ratios that is remarkable improved in this patient that was also hemodynamically compromised. This was also the possibility of, by electric impedance, we were also able to measure perfusion at the bedside, which means that by making an end expiratory pause, you inject 10 cc of hypertonic saline, and you monitor where the electrical signal goes. And the only change in electric impedance by injecting saline is where the hypertonic saline goes, which means blood flow. So what you measure at the bedside, you basically have a map on the right, upper right in blue, of the ventilation, and a map of the perfusion map on the left. And what you do, you can match the quadrants, right and left, upper and lower of the lungs. For example, this patient, before the study, there was in the lower lobe on the right, there was a 51% of perfusion, but only 14% of ventilation, with a great mismatch of ventilation perfusion. After recruitment, this has increased more than double, so that the ventilation now is more in the posterior part of the lungs. And for example, perfusion remains high in the lower part of the lungs, such as like 46% on the right lower lung, and 24% instead is double the ventilation, improving ventilation perfusion matching. So, and this is what I think about going back to the pressure volume curve back on the west zones. What we have in the patients like that is that really in obesity, perfusion is not changed as much. What we have said before is that what is changed is the ventilation, and therefore a closing capacity in the lower part, so zone 3, just to zone 3 of west zone, in the lower part, perfusion remains very high. But at that level, if PEEP is not titrated, we are at lower than the closing capacity of the lungs. Therefore, there is going to be a huge shunt of blood. So these were our first 10 patients enrolled in the study we presented. What we found was that the levels of PEEP were remarkably increased, even in these patients with respiratory failure, similar to ARDS and septic shock. PF ratios, as you can see, has increased remarkably, and collapse of the lungs improved from about a third of the lung that were completely collapsed to 2.4%. So what we learned from this second study was that it was possible to homogenize the lungs by performing a decremental PEEP trial after recruiting the lungs, improving both oxygenation and also lung mechanics. But also from a ventilation perfusion perspective, what we learned was that the perfusion distribution appeared not to be altered in this patient population. What is altered is really ventilation distribution. And so with this, I want to just name the people that really helped me in these studies, that are two of my residents and fellows. One is Max Pieroni, the second on the right on the first picture. And this is my team in the ICU. We use a combination of monitoring, as I described, and then also the group tomorrow will present some of the studies that we learn electric impedance tomography at bedside with Marcelo Amato. So we're studying together several animal protocols, and this is again the second group with Maddalena Teggiadroghi, who presented this data at the American Thoracic Society. Thank you.